I'll demonstrate how to do neonatal resuscitation. Imagine we're under a radiant warmer, and here are my equipments. For my equipments, I should have, of course, suction catheter, a stethoscope of suitable sized diaphragm for my newborn. There should be a source of oxygen, connected from it an oxygen tube, ending by an oxygen mask. If my baby needs positive pressure ventilation, I should have bag and mask. Here is the bag, here is the mask, and as you can see, we do have different shaped masks, anatomically shaped mask or rounded mask. However, it should be of suitable size to my baby. For the bag and mask, here is the pop-up valve. Here is the oxygen port where I connect the source of oxygen if I need positive pressure with oxygen. If oxygen to be delivered at 90 to 100%, of course, I connect the source of oxygen and I connect the oxygen reservoir. If endotracheal intubation is needed, I should have straight-bladed laryngoscope. I'm checking it. Here is the bulb on, and I should have extra batteries. Different sized endotracheal tubes differing in their internal diameter, 2.5 millimeter, 3 millimeter, and 3.5 millimeters size according to the size of my baby. If medication is to be given, I should have different sized syringes, from an insulin syringe to a syringe of 3 cc's, 10 cc's, up to 60 ml. For the medication, my first drug and most important drug, I should have epinephrine. And the epinephrine of a dilution 1/10,000. And I'll tell you how to prepare this dilution. For a volume expander, the typical volume expander to be used is normal saline. However, O-negative blood also can be used. This is the umbilical venous catheter, which is considered the easiest intravenous line through which I can deliver medication and volume expander. If positive pressure ventilation will be prolonged, this is the nasogastric tube to insert it for gas to come outside. Of course, my baby should be connected to a pulse oximeter, and I'll demonstrate how to connect the sensor to the oxygen, the pulse oximeter. As you can see, we do have several clean, dry, sterile towels placed under the radiant warmer in order to be warm. I did hand washing, and I should wear the gloves before contacting the baby. After preparing my equipment, how many persons should attend the delivery? At least one person who's responsible for the baby, his only responsibility is the baby, should attend the delivery. He's the one to start resuscitation. If further resuscitative measures are needed, his colleague should come to help him. However, if there is a risk factor anticipating resuscitation exists, from the very beginning, the two persons should attend the delivery. The obstetrician hands the baby to me. I'm putting the baby under the radiant warmer. I'm assessing whether he needs to start resuscitation or not by asking myself, is he full term? Second, what about his muscle tone? Third question, is he breathing or crying? If he is not full term, if he's having poor muscle tone, if he is not breathing nor crying, I should start resuscitation. I decided by assessment that my baby needs neonatal resuscitation. I'll start by initial steps of resuscitation. The first step is warming. I'm now placing the baby under the radiant warmer, and this is the first step for warming. My second step is position the airway. I'm placing the airway in sniffing position, which is slight neck extension. Neither flexed, near hyperextended. What helps me? To put a wrap towel underneath the shoulder of the baby to maintain his sniffing position. Number 3, clear the airway if necessary. It means whenever I see secretions in the oropharynx, I hear gurgling sound, or my baby is soaked with meconium, I should clear. Clear mouth and nose using this suction catheter, which is connected to a suction apparatus. And whenever I clear the secretions, I start by clearing the mouth, then the nose. Never to do the reverse. If you start by clearing the nose of the baby, he might take his first breath and his oropharynx is full of secretions. So first, suction mouth, and suctioning should be gentle and it should be brief to avoid inducing vagal stimulation. So I suction the mouth until I can see no longer any secretions. I suction the right nostril and ensure that the posterior nares is patent, and then again suction the posterior nares and ensure that the posterior opening is patent in order to exclude choanal atresia. Now I finished clearing the airway. I should dry the whole, starting by the head, then the rest of the body, and ensure you discard the wet linen. Never place the baby back on a wet linen. Then reposition the baby again. So I finished drying the whole body, and remember that this works also for warming. I started warming by placing under-radiant warmer. I did position the airway and clearing if necessary, and I now, by drying, I complete the precautions for warming. If my baby by now doesn't take his first breath, I presume this is primary apnea, and I'll do tactile stimulation. How to do tactile stimulation? By gentle rubbing to the back from underneath the warm, clean, dry towels, or by gentle slapping or flicking the sole. That's it for tactile stimulation. If it is primary apnea, my baby will take his first breath. I finished initial steps of resuscitation, and I should do evaluation by 3 things. First, is my baby breathing? So this is respiration. Second, what about his heart rate? How to assess the heart rate? I can use the stethoscope. I count the heart rate in 6 seconds, and then I multiply by 10. For example, if in 6 seconds equals 11 beats, multiplied by 10, so it makes 110. Remember, we no longer palpate the base of the umbilical cord. No longer in order to count the heart rate. It was found to be inaccurate. However, if my baby is connected, and he should be connected to a pulse oximeter, I can check the pulse oximeter for the heart rate. And remember that the pulse oximeter is put in the electricity, and now the probe is either placed on the right wrist or right hand of the baby. Then we connect the probe to the pulse oximeter in order to get the fastest reading for oxygen saturation and heart rate. So the evaluation was by respiration, by heart rate, and the third is by looking at the pulse oximeter for the oxygen saturation. By now, I'm satisfied with oxygen saturation 60 to 65%. This is optimum for after 1 minute after delivery. However, if it is less than that, I should give supplemental oxygen. I'm evaluating my baby regarding his respiration, heart rate, and pulse oximeter. What if his oxygen saturation is below the target? However, he's taking regular breathing, his heart rate exceeds 100, so I give supplemental oxygen. And as we mentioned, this is the flow meter connected to a source of oxygen. This is the oxygen tubing connected to the flow meter. And now I need to deliver free oxygen to my baby. So one of the methods is to connect a face mask. However, the face masks should be of suitable size. It shouldn't cover the eye. It should cover only the nose and the mouth, and there shouldn't be leakage by the chin. So this is not a suitable sized mask. In that way, I can use my hand as a cup. I do cupping. So I'll cup my hand. Here is the oxygen tubing. I place the cup over the nose and the mouth of the baby with the oxygen tubing 1 centimeter from nostril, mimicking a mask. And then I check my pulse oximeter, starting by 30% oxygen. And testing. What about the pulse oximeter? Does oxygen reach its target, normal target? Not yet. So I can increase to 40%. Not yet. I can increase to 50%. Not yet. I can increase to 60%. So as you can see, we are increasing oxygen concentration delivered to the baby gradually, starting by 30% and increasing 10% by 10% until I reach the target oxygen saturation. At 60% oxygen, I reach target oxygen saturation. By now, I'll do the gradual decrease of oxygen. So I reduce from 60 to 50, still oxygen saturation preserved, 40, still preserved, 30, still preserved. Now on 21%, and my baby is preserving his targeted normal oxygen saturation. So I weaned oxygen now gradually. I finished initial steps of resuscitation. I checked my baby's breathing. I can see my baby to be apneic or gasping. In this way, I should go to the next step, which is positive pressure ventilation. A third scenario. I finished initial steps of resuscitation. I checked breathing. He's breathing regularly. However, when I counted the heart rate in 6 seconds multiplied by 10, it was found to be less than 100. This means that I should go to the next step, which is positive pressure ventilation. Remember the first scenario. My baby was breathing regularly, his heart rate above 100, his oxygen saturation was below target, he needed supplemental oxygen. In some occasions, I can reach to 100% oxygen and still my baby didn't reach his targeted oxygen saturation. This means I should go to the next step, which is positive pressure ventilation. As we mentioned, we should have bag and mask with a pop-off valve. Here is the oxygen port, and if we need, this is the oxygen reservoir. First, ask yourself, should you start positive pressure ventilation with room air without connecting oxygen, or to start positive pressure ventilation with oxygen? This depends on gestational age of the baby. If your baby is 35 weeks or more, and needs positive pressure ventilation, you do positive pressure ventilation with room air. So we don't connect oxygen. If your baby is less than 35 weeks, you have the choice either to start positive pressure ventilation with room air, or you can start it with 30% oxygen. Where to stand? I can stand on the right side of my baby. However, I should look tangential to his chest in order to be able to observe rising of the chest. Or I can stand at the head of the baby, and of course I should observe the chest rise while doing positive pressure ventilation. I chose to stand on the right side of my baby, tangentially observing the chest rise. How to place the mask of the oxygen bag? Put it on the rim of the chin, coapting, cover the mouth, then cover the nose without covering the eye. Your fingers of the left hand should be placed on the rim of the mask to ensure good coaptation. You can place your fifth finger to raise the angle of the mouth. However, ensure that you are not pressing on the neck nor injuring the eye. We start by pressure 20 to 25, and we do the count in order to mimic a respiratory rate of 40 to 60. So I'll do it like this. Breathe, 2, 3. Breathe, 2, 3. Breathe, 2, 3. My colleague should have come so long as I've started positive pressure ventilation by now. Breathe, as you can see, I squeeze. 2, 3, I release. Breathe, I expect the chest to rise. 2, 3, I expect the chest to go down, etc. Breathe, 2, 3. Breathe, 2, 3. For how long? We'll continue like this for 15 seconds. And after 15 seconds, my colleague will tell me.
Chest is moving and heart rate increasing.
Okay, so long. Chest is moving, heart rate is increasing. I continue the same for additional 15 seconds. Breathe, 2, 3. Breathe, 2, 3. Breathe, 2, 3. My colleague is having a stopwatch to tell me when the next 15 seconds will end. Another scenario. I started positive pressure ventilation for this baby. Breathe, 2, 3. Breathe, 2, 3. For 15 seconds. My colleague will tell me at the end of the 15 seconds what happened.
Chest is moving and the heart rate not increasing.
So long as chest is moving, so I'm confident about the positive pressure ventilation I'm delivering. I'll continue positive pressure ventilation the same. Breathe, 2, 3. Breathe, 2, 3. Breathe, 2, 3 for additional 15 seconds. I've started positive pressure ventilation for 15 seconds and breathe, 2, 3. Breathe, 2, 3. Breathe, 2, 3. The 15 seconds ended. What about my colleague telling me?
Chest not moving and no heart rate.
Okay, so chest is not moving, heart rate not increasing. I should revise myself. Is my ventilation correct or not? We call it ventilation corrective steps. What are the ventilation corrective steps? They are Mr. SOPA. M for reposition of the mask. R, reposition the head again in the sniffing position. Try yourself by positive pressure. If it works well and good, you continue for 30 seconds of positive pressure ventilation from the time chest moves. If after mask reposition and repositioning the head, still positive pressure ventilation is not moving the chest, so I continue. S, I suction. O, I open the mouth and continue positive pressure ventilation while the mouth is open. P, I increase the pressure. I started by 25, let it 30. Positive pressure ventilation is not moving the chest, make it 35. If not, make it 40, and this is the maximum. If still with positive pressure ventilation, after M, R, S, O, P, still the chest is not moving, I do the A, which is alternative airway insertion. It means I insert endotracheal tube. So let me do ventilation corrective steps. Reposition the mask. So I'll put the mask like this. Okay. Reposition the head. So ensure it is in the sniffing position. And do breathe, 2, 3. Breathe, 2. Chest is not yet moving. Do the S. I'll suction. Mouth and nose. O, open the mouth while ventilating. P, increase the pressure gradually as we mentioned. Still the chest is not moving with positive pressure ventilation, so we do A, insert an alternative airway. Now the chest is moving. From the time the chest starts to move, I start positive pressure ventilation. Breathe, 2, 3. Breathe, 2, 3. Breathe, 2, 3 for a total of 30 seconds. At the end of the 30 seconds, my colleague tells.
Heart rate is 100 and up.
So long as heart rate is 100 or more, I'm satisfied. I continue positive pressure ventilation, but at longer intervals until I'm confident that my baby is taking his regular breathing. I can wean from positive pressure ventilation. So I did the weaning, but gradually until being confident that the baby is taking regular breathing. There is a second scenario. Now, after ventilation corrective steps, the chest is moving. I do positive pressure ventilation for 30 seconds. Breathe, 2, 3, breathe, 2, 3, breathe, 2, 3. 30 seconds ended.
Heart rate is 80.
He tells me heart rate is 80, so it is above 60, but still below 100. I need to recheck my ventilation. So if I didn't do ventilation corrective steps, it is time to do ventilation corrective steps. If I started some of the ventilation corrective steps, but didn't continue the rest, I should do ventilation corrective steps. Third scenario. Now the chest is moving by positive pressure ventilation. Breathe, 2, 3, breathe, 2, 3. I continue for 30 seconds of positive pressure ventilation that moves the chest. Then my colleague tells,
Heart rate is 50.
he tells that heart rate is below 60. So long as heart rate is below 60, I should confirm that I did all ventilation corrective steps, including the last step, which was insertion of an endotracheal tube. So let me show you how to insert an endotracheal tube. I'm standing at the head of the baby, my laryngoscope on the left hand, pushing the tongue upwards, and through the right corner, I insert the suitable size of the endotracheal tube into the trachea from the right corner. Now, the endotracheal tube is on, and we'll do positive pressure ventilation through the endotracheal tube to ensure that it goes to the proper place. Breathe, 2, 3. Breathe, 2, 3. Breathe, 2, 3. I need to ensure that the chest moves with the squeeze and goes down with the release. Okay? Another tip. If he still insists that the heart rate is below 60, I should confirm that I'm giving oxygen, 100% oxygen. So if I wasn't using oxygen from the start, ensure you're connecting oxygen. Ensure that it is in 100% concentration. And of course, I should connect oxygen reservoir to ensure what reaches my baby is 100% oxygen. Recheck heart rate, please. Breathe, 2, 3. Breathe, 2, 3. Breathe. Still heart rate below 60?
Yes.
Okay. If it is still below 60, so this means I should go to the next step. However, ensure you inserted the endotracheal tube. Ensure you connected oxygen at 100% concentration. If still heart rate is below 60, we will go to the next step, which is coordinated chest compression and positive pressure ventilation. Now it is indicated to do coordinated chest compression and positive pressure ventilation because after 30 seconds of positive pressure ventilation that moves the chest through an endotracheal tube, giving 100% oxygen, the heart rate is still below 60. So long as we inserted the endotracheal tube, I'll do the chest compression while I'm standing at the head of the baby. Where to compress? This is the subcostal margin, xiphoid. This is the angle between the line between the nipples. So this is the lower third of the sternum where I'll compress. We're having thumb technique. 2 thumbs compressing the lower third of the sternum while the rest of the fingers supporting the back. And this is how we'll do it. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. Remember, 1 and 2 and 3, I still touch the skin while he's doing the breathe, okay? Don't release your fingers from the skin in order to be ready to the next cycle. Another method of coordinated chest compression and positive pressure by using 2 fingers. My left hand supporting the back, my right 2 fingers, middle and index, are compressing the lower third. 1 and 2 and 3 and breathe. Without doing like this or doing like this, I should be perpendicular with the support of the left hand behind the back. 1 and 2 and 3 and breathe. So we continue this coordinated chest compression and positive pressure ventilation for 60 seconds. At the end of the 60 seconds, my colleague will tell me about the heart rate.
100.
So long as it is 100 or above, this means that I no longer need to do the chest compression. He'll continue with positive pressure, breathe, 2, 3, breathe, 2, 3, and increasing the intervals, breathe, 2, 3, 4, 5, breathe, 2, 3, 4, 5, 6. Now we're confident that our baby is taking regular breathing. We can stop positive pressure ventilation. A second possibility is after coordinated chest compression and positive pressure ventilation for 60 seconds, while counting the heart rate, my colleague tells
80.
It's 80. So it's between above 60 but still below 100. It means that no longer chest compression is needed. However, he'll continue with positive pressure. Breathe, 2, 3. Breathe, 2, 3. Breathe, 2, 3. A third possibility is after coordinated chest compression and positive pressure for 60 seconds, my colleague tells that heart rate is
50.
Below 60. So long as it is below 60, I continue 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe. Our third colleague is preparing for the medication because it is now indicated. Our colleague is preparing the epinephrine at 1 over 10,000 concentration by withdrawing the 1 cc epinephrine, which is 1 over 1,000, and then completing it by additional 9 cc's of saline, completing the whole volume to 10 cc. Now epinephrine is 1 over 10,000 concentration. How to give epinephrine? We have one of two routes. While we continue chest compression, coordinated chest compression and positive pressure ventilation, our colleague will give the first dose epinephrine through the endotracheal tube. Our 3 kilo baby can be given half to 1 ml per kilo. So can be given 1.5 ml up to 3 ml through the endotracheal tube. 1 and 2 and 3, breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. After 5 minutes, if heart rate is still below 60, this means that a second dose epinephrine can be given, and in this respect, it should be given intravenously. So our colleague should have by now inserted an umbilical venous catheter to be ready for second dose epinephrine. Now the dose, the intravenous dose, is given at 0.1 to 0.3 ml. So our 3 kilogram baby will be given 0.3 up to 0.9. By the insulin syringe, it can be given 30 up to 30 marks or up to 90 marks. So this is the second dose of epinephrine. Of course, we'll continue the same. And we'll recheck the heart rate. If by now it is improving, well and good. If still below 60, after additional 5 seconds, we can give a second dose of epinephrine again intravenously in the same dose, 0.1 to 0.3. Now, what about the volume expander? When to give volume expander, and we mentioned it is either normal saline or O negative blood. We should have evidence of shock. For example, pale baby. For example, capillary refill time is prolonged. For example, weak pulsations, or a history of blood loss. For example, there is severe antepartum hemorrhage. In a twin, there is twin-to-twin transfusion. There is abruptio placentae or placenta previa. There is twisted cord around the neck. And our volume expander will now be given, of course, intravenously in a dose of 10 ml per kilo. So our baby, who is 3 kilogram, will be given 30 ml normal saline. And as we mentioned, it is to be given intravenously. However, it is given slowly over 5 to 10 minutes. All the time, We do continue positive pressure ventilation and 2 and 3, 1 and 2 and 3, and breathe while he's given the volume expander. If still our baby is having a heart rate below 60 and not improving, however, it is not 0. So we should transport our baby while doing the 3 things: the coordinated chest compression and positive pressure ventilation, ending the doses of epinephrine, giving volume expander if it is indicated, in order to be connected to a mechanical ventilator.